Let's go ahead and get started this morning with Grand Rounds. This morning our guest speaker is Dr. Corneille from the Division of Trauma and Emergency Surgery. Dr. Corneille said he was born in Manhattan but got out very early. Actually spent most of his life in Virginia Beach, went to his undergraduate at the University of Virginia, and then attended Eastern Virginia Medical School in Norfolk. And then came here for his general surgery residency and his critical care trauma fellowship, and has been on the faculty since that point in time, and is presently an associate professor. This morning, Dr. Corneille is going to be talking about resuscitation and shock. Dr. Corneille.
Thanks, Dr. Chernick. So I was originally asked to give a lecture on the endpoints of resuscitation, but once I started putting this talk together, I found that there was just too much to talk about shock and resuscitation, much less monitoring. So maybe we'll cover that at a different time. But we're going to talk about shock and resuscitation and a couple papers that have recently come out and try to develop an algorithm for what's the most appropriate way to resuscitate a patient. Start by talking about shock. Spend about the first 20-30 minutes talking about oxygen delivery, and then talk about resuscitation and strategies for resuscitation, what's the ideal resuscitation fluid, and talk a little bit about blood component ratios, since this talk on resuscitation wouldn't really be complete without that. So we'll start by talking about shock. And some of these slides are ones that some of you have seen before, but not everyone. So shock has been traditionally defined by the etiology. Shock can be described as hypovolemic, including hemorrhagic shock, septic shock associated with capillary leak, distributive, which would be neurogenic shock, anaphylactic shock, cardiogenic shock, which can be primary pump failure from, for instance, a myocardial infarction, or compressive shock with cardiac tamponade and tension pneumothorax. This traditional classification scheme describes the process, but it doesn't really get to the etiology and doesn't really tell you how to fix it necessarily. Tissue hypoxia is the final common pathway of each of these etiologies. And a definition for shock really is better described not in terms of the etiology, but in terms of oxygen demand. So shock is defined, and most of you obviously know this, shock is defined when cellular oxygen demand exceeds supply, or DO2 exceeds or is inadequate to meet VO2, which is consumption. Oxygen delivery at rest is about 1 liter per minute, and consumption at rest is about 250 cc's per minute, which means that about 25% of oxygen that's delivered is actually utilized. Different tissues extract oxygen at different rates. For instance, a myocardium is 50 to 90% extraction ratio, depending on whether or not it's in an active state. Looked at a different way, arterial blood should be 100% saturated. Mixed venous blood, so right before it goes into the pulmonary, or at the level of the pulmonary artery, should be saturated about 75%, which means about 25% is consumed. So the oxygen extraction ratio at rest should be 1 to 4, and there should be about 4 to 1 redundancy in oxygen delivery. So we're going to do a little bit of math, some equations. Oxygen delivery is arterial oxygen content times cardiac output. Oxygen content can be described as the oxygen contained on hemoglobin, so the amount of oxygen dissolved on hemoglobin, plus the amount of oxygen dissolved on plasma. Because the partial pressure of oxygen, so the amount that's dissolved in the serum or in the plasma, is multiplied times 0.003, that essentially drops out, and that leaves you with the hemoglobin and the saturation. Since oxygen delivery again, content times cardiac output. Cardiac output can be described as mean arterial pressure minus CVP times the systemic vascular resistance times 80. It can also be described as heart rate times stroke volume. This can further be broken down into the end-diastolic volume times the ejection fraction. The central venous pressure, being that it approaches zero, essentially drops out. And so what's left becomes the mean arterial pressure, systemic vascular resistance, heart rate, end-diastolic volume, ejection fraction, hemoglobin, and oxygen saturation. And so shock, which was traditionally defined by etiology, can instead be defined in terms of oxygen delivery. So cardiogenic shock represents a failure of ejection fraction. Compressive shock represents a failure of end-diastolic volume. Distributive shock represents failure of systemic vascular resistance. And hemorrhagic shock represents a failure of end-diastolic volume and inadequate hemoglobin to meet oxygen delivery. So this is well summarized in an article that talks about basically 7 levers of manipulation to improve oxygen delivery. And I spend time to talk about this because this is one of the key tenets of critical care, which is ensuring adequate oxygen delivery. And then resuscitation essentially is achieved through these 7 channels. So we talked about oxygen delivery. What about oxygen consumption? Oxygen consumption occurs at the level of the mitochondria, and is in essence the difference between the arterial oxygen content and the venous oxygen content. So again, that extraction ratio of about 1 to 4. And this describes the O2 consumption at different points in the body. So the myocardium and skeletal muscle clearly have very high oxygen consumption per 100 grams of tissue compared to, for instance, skin, which is and resting skeletal muscle, which is very small. Critical oxygen delivery is the point at which shock and resuscitation converge. And what this describes is that within this range, the redundancy, that 4-to-1 redundancy, may regress to 3-to-1, 2-to-1, 1-to-1, and at this point, oxygen delivery is inadequate to meet oxygen consumption. And so this is described as a critical oxygen delivery at this point. This is where shock begins and resuscitation begins. It's critical to try to understand this point. Concept of oxygen debt refers to, and it's really as much conceptual as anything. It's never been measured. You can't really measure at the mitochondrial level the amount of oxygen that's there or missing. But the concept is that when metabolic demand exceeds oxygen supply, that in order for resuscitation to occur, this debt has to be repaid. So essentially, all of the oxygen is consumed in the O2 transport chain and needs to be restored by perfusion. Without restoration of this oxygen debt, anaerobic metabolism and inefficient ATP production continues. Shock can be compensated or uncompensated. Compensated shock represents a mild global oxygen debt, which can be supplemented by O2 delivery. In compensated shock, oxygen debt surpasses the physiologic means to replace it. And this can be a reversible state or it can be an irreversible state as well. In compensated shock, vital signs are maintained. Urine output's maintained, heart rate's maintained, blood pressure may be maintained. There may be some global, some systemic signs of oxygen debt, including increases in lactic acid and increases in base deficit. The compensation occurs through increasing contractility, increasing diastolic blood pressure afterload, increasing the preload by attempting to draw fluid from the cells and from the interstitium. Additionally, shunting prioritizes oxygen delivery away from more hypoxia-tolerant tissue to tissues that are less hypoxia-tolerant, including the brain and heart, those with a high oxygen extraction ratio and high metabolic demand. In compensated shock, hemodynamics are maintained, although there may be isolated tissue beds which are ischemic and where demand exceeds supply. In uncompensated shock, shunting, ejection fraction, all of those mechanisms are essentially exhausted. And so some resuscitation must occur, otherwise this will lead to an irreversible state. And this can occur through fluid resuscitation. It's been described through pharmacologic augmentation. So all of this depends on what state is being, or what the etiology of the shock is. Mechanical ventilation to increase oxygenation, red blood cell transfusion to increase hemoglobin. All of these are mechanisms by which oxygen delivery can be enhanced. And so as shock goes from compensated to uncompensated, it can also be looked at as going from a state of reversible ischemia to irreversible necrosis. So an example of this might be in the kidney, a kidney that there are many patients who we have that experience shock, but a certain small portion of those experience acute tubular necrosis. As shock goes from compensated to uncompensated, so this represents compensated shock, uncompensated shock here. This is where the opportunity for diagnosis, intervention, prevention, and resuscitation is. So we'll spend some time talking about resuscitate. With that brief background, I'll spend some time talking about resuscitation. So if shock can be described as cellular oxygen demand not meeting consumptive needs, resuscitation occurs when that oxygen debt has been repaid. When tissue acidosis is eliminated and when aerobic metabolism has been restored. So back to that slide about hemorrhagic shock. If hemorrhagic shock represents a failure of preload and hemoglobin, if you kind of rearrange those and isolate just preload and hemoglobin, then all of the other strategies that have been tried, or many of the other strategies that have been tried to try to combat hemorrhagic shock, which is what I'm going to talk about. Not enough time to discuss sepsis, et cetera, et cetera. But in hemorrhagic shock, each of these strategies, they're not at all random. They are specifically trying to address what is the failure of oxygen delivery in the setting of hemorrhagic shock. And so the first thing I'm going to talk about is volume resuscitation, crystalloid versus colloid. In the search for the optimal fluid resuscitation method, the choices are summarized as isotonic crystalloid, hypertonic colloid, hypertonic crystalloid, artificial colloids, including starches. Several of the trials that have been done have included combinations of both hypertonic crystalloid and artificial colloid being a starch. Plasma, fresh whole blood, artificial blood. These hemoglobin-based oxygen carriers really look like they would be promising, but really have not come to fruition. And so each of these has potential benefits and potential harms. Isotonic crystalloid it's obviously an effective volume expander, but has been shown both lactated ringers, normal saline, to cause immune activation. And if you subscribe to the two-hit theory that the initial resuscitative fluid may actually be further priming or aggravating that initial immune response, may lead to lung injury and other tissue injury. Hypertonic saline actually probably has some immune suppression, which initially you think immune suppression, you don't think that might be a good thing, but going back to that two-hit theory, with trauma, the immune system is already primed, and so the thought is that potentially the immune suppression associated with hypertonic saline might be of benefit. We know that artificial colloids, starches, are effective volume expanders, but they too cause some immune activation, and there have been several reports of coagulopathy associated with using starches. Plasma has a significant benefit of being a procoagulant, but it has its own intrinsic immune activation. So transfusion of white cells associated with plasma transfusion may, in and of itself, cause immune activation and probably contributes more to transfusion-related lung injury than transfusion of red cells, even though we usually think of TRALI as being associated with red blood cell transfusion. Fresh whole blood has the advantage of being an oxygen carrier as well as a procoagulant, but isn't really available here. It's been used pretty extensively in combat, but currently really in the U.S. Is really not available. Hemoglobin-based oxygen carriers, as I said, have the advantage of being an oxygen carrier, but have all sorts of problems, and in clinical trials were not shown to be an improvement over conventional means, and may have an increased risk of MI. Some of them have been associated with renal failure. They cause, with that free hemoglobin, seems to scavenge nitric oxide and cause secondary hypertension. And so we're not really going to talk about fresh whole blood or hemoglobin-based oxygen carriers because they're either not available or not available for us readily here. So isotonic crystalloid, it's cheap, it's available, it's familiar. Why use hypertonic? The advantage to using a hypertonic saline is that you can achieve intravascular volume expansion with a relatively small volume, small intravenous volume. So if weight or space is an issue, then having the ability to resuscitate using a relatively small volume of fluid is appealing. Hypertonic saline probably improves cerebral perfusion because of associated decrease in intracranial pressure, and this is part of the mainstay of management of intracranial hypertension. I've mentioned the immune advantage in that it modulates the inflammatory response, and it's thought that because of this may decrease the development of late multiple organ failure. And so given these presumed benefits, this study was conceived and published in 94. I told you I was going to talk about 2011, but I'll take you back to 94 first, because use of hypertonic saline has a pretty long history in resuscitation research. This was a multi-center trial. There had been previous single-center trials to try to assess the utility and benefit using hypertonic saline. But this was the first large multi-center trial. They enrolled patients with a blood pressure less than 90 and patients that were less than an hour out from their injury. The formulation that they tested was 7.5% normal saline plus dextran. So a hypertonic saline dextran solution. Some you might see that abbreviated HDS in the literature. And compared that to 250 cc's of standard whatever resuscitation fluid, be it normal saline, lactated ringers. They were able to enroll 422 patients, but found mortality. I can't remember if they said 30-day or 28-day mortality, but mortality essentially was no difference. They concluded that it's safe, hypertonic saline dextran. It's safe, and it's at least equivalent to conventional resuscitation. So it can be used again if space or weight is an issue. For instance, in a combat or transport situation, it's at least as good as conventional crystalloid, but no difference in survival. The problem with this study, and the problem with many of the other studies, is that it was underpowered to be able to show a difference. So they needed at least 700 patients to be able to show effect, but were only able to enroll 422. I put this slide up here not because I expect you to actually read all these titles, but just to show that in the intervening years there have been numerous trials of hypertonic saline, but you probably ask yourself, how come that's not what we use if there's so much interest and so many people have tried to show that it's effective and useful. Most of these trials were stopped for futility, ended up being underpowered to be able to show a difference. That is the large either single center or multi-center trials. They really weren't able to show a difference. And so those proponents of hypertonic saline use, recognizing the potential benefit in brain injury, recognizing the potential benefit in immune modulation, the benefit in the military setting of being able to carry a small volume of fluid for the same effective volume expansion as conventional crystalloid, tried to answer this question with this study. So this came out a couple months ago. It was a study that was a large multi-center study. So if they couldn't answer it with 3 centers, that first study from 95 was 3 centers. This was actually a 114-center prospective randomized controlled trial that was conducted by the NIH-funded Resuscitation Outcomes Consortium, or the ROC Consortium. They included injured hypotensive adults, anyone older than 16, and the study had 3 arms. They, same as before, initial infusion of 250 cc's of hypertonic saline. Why only 250 cc's? Because of the enhanced ability of hypertonic saline for volume expansion. You don't need to give a liter like you might need to for LR or another isotonic solution. So 250 cc's, and they had 3 arms. One was hypertonic saline dextran, one was hypertonic saline alone, and the other was normal saline, so 0.9%. And the primary outcome was 28-day survival. Unfortunately, similar to the studies before, this one was also stopped early because of futility and potential safety concern. In other words, these patients were getting hypertonic saline and were not getting necessarily conventional resuscitation. They were only able to achieve 23% of the proposed sample size. That was 853 patients. And you can see the numbers, a non-significant difference in 28-day survival. The hypertonic saline dextran group, 75%, all of them around 75%. So no difference in survival. The study actually had two major studies concurrently. They looked at trauma patients in hemorrhagic shock. They also looked at brain-injured patients. They were able to enroll 1,331 patients in that study, which was stopped at the same time, and showed no difference in 6-month survival or neurologic outcome. And so the authors concluded from this study, as they have from many of the previous studies, that hypertonic saline, it's safe, it's effective, but there's really been no demonstrated benefit over isotonic solution. And so really the only place where it may be the fluid of choice is if space or weight is an issue. So if you're on a plane transporting a patient, then hypertonic saline may have a place. On the battlefield, hypertonic saline may have a place, but it doesn't really seem to confer any benefit in mortality in everyday use. And so we talked a little about crystalloid and colloid. What about another strategy for resuscitation, which is delayed or hypotensive resuscitation? You may see it referred to as permissive resuscitation because the goal is not restoration of cardiac output or mean arterial pressure, so it's referred to as permissive. Resuscitation doesn't begin until hemostasis is achieved. That's the basic concept. The benefit is, at least hypothesized, is that you may be able to avoid hemodilutional coagulopathy, and you may be able to avoid some of the potential harmful effects of crystalloid. So putting that to the test, this was actually a landmark article that came out in '94. It was conducted in Houston. It was a prospective randomized trial. They enrolled almost 600 patients and looked at patients with penetrating torso injuries, so not blunt patients and not patients exsanguinating from extremity trauma, but penetrating torso injuries. They enrolled patients with systolic blood pressure less than 90, and this was essentially a pre-hospital and emergency department. So pre-OR is the break point here between immediate resuscitation and delayed resuscitation. In the immediate resuscitation group, those patients had 2 large bore IVs and given standard IV resuscitation. What was the standard of care in the day? In delayed resuscitation, those patients got IVs. IV access was established, but fluids were not given until the patients were in the operating room and attempts at surgical hemostasis were underway. They were able to show that there was an improvement in survival. 70% survived in the delayed resuscitation arm compared to 62% in the immediate resuscitation arm. So a significant improvement in outcome. And so they concluded from this study that delayed resuscitation improves survival. They also recognized that it seemed to reduce coagulopathy and postulated that it avoids what they called hydraulic disruption of the clot, what you may hear referred to as popping the clot. The idea being that without using blood pressure or cardiac output as an endpoint of resuscitation, that any hemostasis that's achieved will not be overcome by increases in mean arterial pressure. And so those that believe in hypotensive strategy of resuscitation believe that this is really a valid, reasonable alternative to the conventional way that we resuscitate patients, and really what ATLS says and what's practiced in most centers. And so this study, which was published in March of 2003 in the Journal of Trauma, essentially is a continuation of that work. This was also conducted in Houston, and this study is published as an interim analysis of the 90 patients that they enrolled under a similar resuscitation strategy. And so this is their randomization algorithm. At the OR-GOR, essentially, patients are randomized to either receive an intraoperative resuscitation target of a MAP of 50 compared to a MAP of 65. And so that first study that I showed you focused on the pre-hospital and emergency department, and their hypothesis in this study is that if that worked well, then perhaps an intraoperative strategy of hypotensive resuscitation would work as well. They had their results showed that they had an equivalent mortality in those two groups. The HMAP being the high mean arterial pressure versus low mean arterial pressure. So this is again an interim analysis after 90 patients. They haven't achieved their enrollment goal, but wanted to look at their results to ensure that they were not causing any harm. So even though the mortality was equivalent in those two groups, they observed, and you might call it spin, but they observed that in the high MAP group that the bleeding mortality associated with coagulopathy in their clinical judgment was less in the low MAP group. So in the high MAP group, I'm sorry, I think I reversed these. In the low MAP group, in the low MAP group, 0 out of 6, sorry, these are reversed. In the low MAP group, these deaths here, they recognized that, or assessed that they had 0 deaths associated with coagulopathy, compared to in the high MAP group, those 10 deaths, they attributed 7 to coagulopathy. So this is basically in keeping with their hypothesis, maybe prove their bias, but they concluded that hypotensive resuscitation is safe, and that even though the 28-day mortality was equivalent, that maybe less coagulopathy occurs, and they also conclude that this makes sense biologically because of the known pathophysiology of the lethal triad of acidosis, hypothermia, and coagulopathy that's associated with high volume resuscitation. And so, as I said, it wouldn't be a complete discussion on resuscitation in 2011 without discussion of the optimal plasma to red cell to platelet ratio. So the concept of damage control has been around since the early to mid 80s, and the basic tenets are that intervention should be abbreviated in order to restore physiology as a priority rather than anatomy. So rather than take patients with bad liver trauma and open their liver and let them get 50, 60, 100 units of transfusion, ultimately to bleed to death in the operating room, the concept of damage control suggests that those procedures should be brief, that control of hemorrhage should be paramount, but that once surgical bleeding is controlled, that interventions to avoid acidosis, hypothermia, and coagulopathy actually take precedence. And there are numerous studies showing the mortality benefit of this approach. With regard to avoidance of coagulopathy, ATLS really prescribes a sequential approach to resuscitation. So crystalloid, 2 liters of crystalloid followed by red blood cell transfusion, 2 units of red blood cells, followed then by plasma, and subscribes to the traditional 1-to-3 ratio of red cells to plasma. We transfuse components now. We don't transfuse whole blood. If we were transfusing whole blood, this really wouldn't be a question, and that's what some of the proponents of whole blood transfusion suggest, that we don't have to worry about optimal ratios. The patient is bleeding blood. We should give them blood. This is a study that we participated in here. Dr. Mahalik's one of the authors in the audience here. This was a retrospective multi-center study which included 466 patients who were massively transfused. So that's patients that received 10 or more units of red cells. And patients were divided into groups based on the ratio of components that they received. So compared to red cells, patients that were less than 1 to 2 red cells to plasma, red cells to platelets, were considered low, and the reverse, greater than 1 to 2, were in the high ratio group, and compared the mortality. So this may be too small to read, but essentially those patients that had a large number of plasma units and platelet units transfused, their survival, this is hours to death, their survival in the first 24 hours compared to those who had low ratios, in other words, patients who received low volumes, low amounts of plasma and platelets, and these are the ones in between. So if you had lots of red cells and a little bit of plasma, lots of red cells, a little bit of platelets, and not much red cells and not much plasma or platelets, your mortality was lower. And these same results carry out here. I'll give you a little time to look at that because I see Dr. Myers scrutinizing it. Okay. So the problem with this study is the problem with much of the data surrounding this issue. And so I could spend another 2 hours talking about what's the optimum ratio. But most of us have heard described 1-to-1-to-1 red cell to plasma to platelet ratios being the optimum. So most of those studies are retrospective, including the one that I just showed you, but they do show a strong improvement in mortality, and there's been many studies just by looking up the author of that previous study, Dr. Holcomb. There were 38 studies that he's been an author on, much less all of the other studies that have come out really in the past 5 or so years, describing what the optimum ratio of red cells to plasma to platelets is. The fundamental problem with this retrospective data is that there's a strong time bias. In other words, patients who are alive long enough to receive high ratios of plasma to red cells and high ratios of platelets to red cells are, in general, those patients, because they're alive, they were able to get those transfusions. So when you look in retrospect, the data are not as strong. The other thing when you talk about one-to-one-to-one, even in the best hands and in the hands of the evangelists who preach one-to-one-to-one, find that they can't get there. So it's usually 1 to 1.3, so 1 unit of red cells to 1.3 of plasma, and even higher for platelets. So it's actually difficult to achieve. So rather than thinking that's necessarily the optimum, it may be that that's really the optimum target. Whether or not it's achieved and whether or not achieving one-to-one has any benefit remains to be seen. Nonetheless, it has become the standard of care. It's what we practice here, and it's what most level 1 trauma centers try to achieve. Hopefully, this question will be able to be answered by the PROMPT study, which is the prospective massive, I can't remember what that other M is, prospective massive transfusion trial, which is a multi-center. Prospective observational multi-center massive transfusion trial. And so this is a large study, again, which we participated in here, which patients who received 10 or more, or patients were screened for massive transfusion with the goal of looking at patients who had 10 or more units of red cells transfused with a goal of 1-to-1-to-1 to assess whether or not that strategy is associated with a survival benefit. And so to summarize, shock is when tissue consumption exceeds oxygen delivery, and resuscitation is not, it's not random. Resuscitation occurs through clearly defined strategies and channels. So what should our initial resuscitation strategy be? I've presented you a lot of data, a lot of point and counterpoint, and so I'll tell you what I believe. Our initial resuscitation strategy should include some judicious use of isotonic crystalloid. So volume expansion to achieve a normal blood pressure, I do not believe should be our goal, and I think the data are pretty strong in support of not using a normal blood pressure as a target, and that to that end, permissive hypotension probably has some benefit, but of course you have to balance between permissive hypotension and irreversible oxygen debt leading to death. And so maybe the question isn't whether or not it has benefit, but in which patient population. And even though 1-to-1-to-1 remains to be demonstrated whether or not that transfusion strategy has some mortality benefit, the reason why it has become the standard of care is because most people that operate on trauma and patients that have massive transfusions have recognized that their own experience is that patients that have this resuscitation strategy followed have less coagulopathy. That if you just transfuse a patient red cells, particularly if you transfuse a patient cold red cells, they will become coagulopathic in a hurry, and that by infusing plasma early, it seems to avoid some of this. So what the appropriate ratio is unclear. Maybe it's greater than 1-to-1. Who knows? But early plasma and platelet transfusion should be standard in resuscitation. And so with that, I'm happy to answer any questions, and thank you for your attention. Questions? Dr. Myers.
On Madison's 2011 paper,
Mm-hmm. Mm-hmm. Mm-hmm.
Two questions. One, I know they lived by the don't resuscitate until you get it to the OR.
Mm-hmm.
Were those volumes controlled for the pre-hospital and the EC resuscitation?
The pre-hospital was basically standard. They weren't randomized until they hit the OR. So in light of all of the other studies that have come out of Houston describing low volume resuscitation, that's probably part of their culture. But no, they weren't. They didn't control for pre-hospital. Randomized at the door.
So that's what we assume, because it's coming out of Houston and Tim Max's name is on the paper, that was a hypertensive resuscitation pre-hospital emergency.
Say that again. Were the volumes different?
We're assuming that it was low volume resuscitation prior to damage control.
Correct. Correct.
So we're assuming that those volumes were low and equal in those 2 groups.
Yes. I believe so. I have to go back and look, but truly there was no knowledge of what arm of the study they would be in until they hit the operating room. So the demographics and overview that I remember, they were equivalent groups.
And then the second question, in the late deaths,
In the late deaths in...
we have the less than 24-hour deaths, and it looks like...
Yeah, actually, let me show you that slide, because they... I don't... Yeah. I don't think I have... I'm not sure. So it was 28-day mortality, and so I don't know if they... I'm sure they have a cause of death analysis. I can look that up and get back to you.
Very nice talk, and I think it leads to some of the things that we do, and probably people here and back there, we do it because that's the way we do it. We'll just sort of put some data and reason on it. The things we don't do,
Mike, one of the variables is delay to resuscitation. When we were at the burn unit, we could tell the difference whether people got immediate resuscitation as far as how much volume they required. None of that's ever figured in any of these studies as far as one variability. And I think it plays an important role. So there's a delay in therapy.
That second low permissive hypotension study, less than an hour from injury. So they controlled for anyone who had a delay to treatment was not included.
I was just thinking about the garden variety person coming into the ER that you have to go ahead and treat.
And Ken, the burn and the bleeding resuscitation is different. The burn resuscitation, you're not going to control it. It's not something you can go. Thank you, Jason. There's something you can go and fix and stop bleeding, and so you quit losing volume. So I think they're a little bit different, although the principles are the same.
Mike, a couple of questions. You had a series of papers that you talked about, hypertonic saline. All of them underpowered. All of them stopped early. Okay. First question is why? Why were they all stopped early? And then the second question is, has there been any attempt to kind of salvage all this data in a meta-analysis? I mean, you've got lots of underpowered trials. Why not try to get a more definitive answer by putting these things together in a meta-analysis?
So the ones that were stopped early, many of them were stopped early for futility because of rates of enrollment at a single center. The patients that we're talking about, they want patients in shock, and so even though it seems like every night we have those patients, really, and the prompt study showed us this, that the number of massive transfusions that we have in a year is not nearly as great as we think. So, I mean, I can't remember the numbers. If you can remember the numbers, Dr. Myers, Dr. Lau, how many massive transfusions we have in a year, it's, I don't know.
In the last 6-month period, we had about 45.
So it seems like there should be, do you know if that's 6 units or 10 units? 10 units. So it seems like you should be able to accrue those patients relatively quickly, but what ends up happening is those studies end up being stopped for not showing any benefit at interim analysis. with ongoing, essentially accrual problems.
So the question is, why do an interim analysis? Why not just do analysis of the endpoint?
The question of harm. So, I mean...
But if there's a trial, there's equipoise, so you don't know if there's going to be harm or benefit. I'm just... I'm talking from an oncologist point of view, because that comes up in oncology literature as well. So we just do, the analysis at the endpoint.
So the first study was
Not
underpowered.
unreasonable.
The next one, it was underpowered, and they went ahead and made 3 treatment groups instead of 2.
Well, one point that I didn't mention, that first study was a 3-center trial. So I made the point that ROC consortium, Resuscitation Outcome Consortium study, it was 114 studies to try to definitively answer this question that had been attempted to be answered in 3 busy, Seattle, Houston, and Milwaukee, 3 busy places, couldn't answer the question. And so that NIH ROC trial is essentially the largest trauma, resuscitation, critical care group that we have, and still not really showing a benefit. I just think the enticement is so great because of the presumed benefits of hypertonic saline, but it just hasn't been able, the mortality benefit has not been able to be demonstrated.
So the last question is, can we salvage this data with a meta-analysis? Why not combine all these underpowered trials to try to get an answer?
So meta-analyses have been done and have shown the same results as those smaller trials, but as I know that because I know there's a lot of meta-analyses in cancer research as well, meta-analysis versus the definitive randomized controlled trial, I still want to really try to answer that question.
Were the initial studies with hypertonic saline with dextran, if I remember correctly, Blaisdell, it was UC Davis. I can't remember the other guy, Jim, who was the big proponent.
Bickel is the first author on that. Bickel, I think, is the first.
Yeah, no, but I mean, there's one guy that was at UC Davis. Can you remember his name, Wayne? I can't remember the trauma guy at UC Davis with Blaisdell. And I don't think they had dextran originally. Was that added?
Any number of smaller studies that looked at hypertonic saline, that looked at hypertonic saline dextran combinations, that looked at 6%, 7.5%. Any number of smaller studies that were done, and each of these studies, almost to a T, shows it's at least equivalent. It's at least as equivalent to crystalloid resuscitation.
Dr. Corneille, that's actually sort of what I was going to touch on. In addition to the fact that all those trials with hypertonic saline were underpowered, at least all the ones you cited here actually compared equal volumes of hypertonic and isotonic, which seems like that's sort of not answering the real question. It seems like the question, and even the authors of those papers' own contention, is that the benefit may lie in reaching the same result with lower volumes, but that's not really... Yet all of them compared equal volumes.
Given a larger volume.
Yeah, in other words, they all compared 250 cc's to 250 cc's, but then at the end they say, well, the benefit may be that you can get the same resuscitation with 250 cc's versus a liter, which is not the comparison they made in there in those trials.
I think it's a great point.
Dr. Schlesinger.
Let's just step back towards basic science a little bit. Considering the importance of the concept of oxygen debt to this whole issue of resuscitation, you would think by now there would be a method of measuring oxygen debt at the subcellular level. I mean, basically all we're looking at is lactate. Is that as good as it gets? That was what it was 30 years ago.
Dr. Cernik made a similar point to me prior to starting the talk. So originally I had intended to talk about shock resuscitation and monitoring, but found that once I kind of got into resuscitation, monitoring is a whole other talk. So techniques that might get at what you're describing is near-infrared spectroscopy. So to be able to look at the tissue level, to be able to see what is the oxygen state of a given muscle bed. And the study, it was a study that Dr. Cohn was the PI on here, showed, yes, it works. You can get at it you can follow it. You can follow it in real time. in terms of predicting outcome, it's as good as space deficit. So you can monitor. It's not been studied necessarily as an endpoint of resuscitation per se, like, for instance, mixed venous O2 saturation, for instance. Hasn't really been, NIR hasn't really been studied in that way, but it certainly could be.
We were joking that we actually need a probe sitting in the mitochondria to see exactly how dysfunctional it is, whether it's only making 40 ATPs instead of 46. Dr. ate a lot.
Does anyone else think this is just kind of funny? I mean, we do all these studies after study after study after study for, okay, what are you going to study again? Bleeding people. They got shot, they wrecked their car, whatever. They're bleeding to death. What we're going to study is giving them all the stuff that's not blood. And it turns out, study after study after study, they don't really make a difference. Whatever thing that's not blood we give them. Well, I'm just imagining over the next 30 years, maybe I'll be sitting here and someone will be presenting a paper and they'll say, oh, and you know what, we did it for another 30 years and it turns out there's no difference. It seems like the only thing that's really made a difference, and I understand it's retrospective, I understand the timing portion of it, I get that whole concept, is, well, they're bleeding blood, so why don't we try to give them something that looks like what they're bleeding? The reconstitution of whole blood. And it seems like the next frontier of this is going to be that thing that we all tiptoe around that we think that we cannot do, which is giving somebody whole blood here in America. Someone will figure out like the mechanism of making that happen. I don't know if it's bleeding a bunch of college students on a Friday night. I mean, that's kind of what I'm going to propose. But yeah, I know the blood alcohol content. Maybe we could just
In blood banks or outside?
you know, but it seems. I mean, it was a really good talk and a great wrap up of, like, I mean, crystalloid. Are we really going to keep doing that or keep studying that? I just think that I'm not sure how fruitful that'll be. I think the new frontier is going to be fresh whole blood.
I agree with you, and the proponents of one-to-one-to-one transfusion now talk about hemostatic transfusion. And so they're also investigating what other off-the-shelf sorts of adjuncts would be useful to restore the coagulation, because whole blood, as I pointed out, restores both oxygen carrying capacity and hemostasis. The problem is it's a resource problem, it's an expense problem, it's a cost problem, and it's also being able to, and I think the most important problem which the PROMPT trial hopes to address is the patient population. In whom do you give? So ideally, you would be able to know the future. The patient gets to the door. Is this someone who's going to bleed 10 units of red cells? Give that guy whole blood. Start by giving that guy whole blood. He bled whole blood. Give him back whole blood. The problem is if you, for every patient that comes in that needs a transfusion, and this is just trauma, much less everybody else that needs a massive transfusion, liver transplant patients, big, oncology procedures, giving all those patients whole blood, we'd run out of whole blood next week. And so it really is a resource issue as much as any, although to your point, they bled blood, give them back blood makes the most sense if you've got it.
When the military came here and reported it, they had all those young, healthy guys right on base, and they said, you will donate today. I suppose we could call upon our medical students who are rotating on trauma to become donors to get an A or a B.
They don't look like they're in that good a shape.
A grade. Anything else? All right, listen, thank you very much.
Thank you.